Okay, I'm going to be demonstrating the admission forms we have for admitting a patient for surgery. So when a patient comes in for surgery, we have our what we call our top sheet and our admission form. So this is what gets traveled around with the patient and has all of its information. It has the last name of the patient, today's date, the patient's name, the patient's ID number, and the procedures that we're doing along with the surgeon. So any of the procedures, plus any extra things like IV fluids or microchip or vaccines, and then any medications to go home will go down here. We can look up the patient's PET ID number to pull up the full medical record so we can see the sex, the breed, anything like that. So we have, this is Milo, and we've got Milo's medical record pulled up here on our database. So we can see that Milo is a domestic short-hair male cat. He's 17 weeks old. He is black in color, and he's 4.92 pounds. So I have all that information. If we have this, we can access this, and we know exactly what we're doing and who he is. Okay, I'm going to be showing you guys this patient's permanent medical record. So we can see we have all of the client's information in our medical record database, as well as all the patient's information, such as the age, the sex, the color of the patient, the weight, things like that. All the information is up here in the top. We also have a picture of the patient to make sure we actually have the correct patient. If you can scroll down, we have our permanent medical records. This is all of our information. This is a new patient with us today, so we don't have a whole lot on him, but we have all the info that he came in today with. So he's here for neuter, so we have our reason for visit. We have our anesthetic consent form that we can, the client has signed, and we also have the SOAP exam that our doctor filled out this morning and did an exam. So we have all of this info. Whoops, scroll down. All of this info inside, and you can see he's normal condition and everything, and then the doctor says plans to proceed with surgery. So we have all of that information, and as well as our anesthetic monitoring form. If this patient were to have vaccines, he doesn't have any vaccines with us today, but he would have them up here in a box, and we can click on that box and see a full lifetime history of vaccines. Any other anesthetic, or not anesthetic, any other medical records would be categorized by date. So we could, if he were to come in tomorrow, he would get a new box with that day's medical records, and this will stay with this patient forever. Okay, so I have a release and consent form here. We have the printed version here. We have a version in the patient's medical record. This gets stuck to the travel sheet that travels around with the patient, so we can access it at any time if we have any questions whether or not they signed yes or no for something. So at the very top here we have the procedure that's being done, the patient's name, and the owner's name, so we know who this is for. Over here we have whether or not the patient wants vaccines. If they do want vaccines, if they check yes, we write which vaccines they want on the side. They went ahead and checked no for that. The next is whether or not we want them, the owner wants them microchipped. They went ahead and checked no. They have the option to check yes for that. Next we have what's called our preoperative blood work, and this is your basic pre-screen blood work before surgery. All this is describing, how it's important, that we highly recommend it. I tell them, this could show you whether or not your pet maybe has something going on with its organs that maybe you weren't aware about. It's always a good idea to check that and make sure everything's working functioning properly, and how sometimes if they have different kidney values or liver values, it can affect anesthesia and have a negative outcome. So they went ahead and checked no for that, and also we highlight the price of it. At our clinic, we do require that any patient over 7 years of age must have blood work, just because of the risk. So they're aware of that. They went ahead and checked no for that. Next we have our IV fluids, again describing the reasons why IV fluids are important, whether they have a drop in blood pressure or they maybe have kidney problems. The price is here. You can check yes or no. They went ahead and checked no. We have little asterisks here that read, and in case they checked no, in case there is an emergency, we will place one, whether or not they signed yes or no, and the price does go up, just letting them know, hey, we're not going to let your pet have an emergency just because you checked no. We're going to try and fix it, and yes, there will be a charge for that. They're aware of that. Next we have our post-nausea treatment. So this is either a pill or an injection, depending on the patient's attitude towards the subject. Lets them know, hey, there's been studies that have shown pets that have received nausea treatment versus pets that have not. pets that have seem to have a greater appetite sooner, and they don't seem as nauseous, and they're more have a better attitude, and they're just seem to be better. So that lets them know all the information about that. The price difference for patients under a certain weight and the patients over 50 pounds, there's a little bit of price difference. They went ahead and checked no for that. Then we have our laser surgery option. So this is our laser, and I let them know, patients that have had laser surgery, they seem to have less discomfort, less bleeding, they have faster recovery times. Let them know the price on that. They went ahead and checked no for Milo. Next, on the next page, we have our e-collar. I will let clients know that it's always a good idea to protect the surgery site from pets that want to lick it or harm it. And the natural pet instinct is to lick it, make it better, and it's not going to make it better, it's going to make it worse. The possibility for infection or even needing to resedate the patient and resuture or staple. There's a price difference between the different sizes, and then we have here, they went ahead and checked no for that. Next we have these two sections here. The first one talks about whether or not the patient is in heat or not. There's an extra charge for patients in heat because the surgery is a little bit more complicated and takes the doctor a little bit more time. Milo's a boy, so they went ahead and left that one blank. He's not going to go into heat. The next we have is in case the patient is pregnant. And we have different charges for that, whether or not they want to proceed with that. They're also signing, if they don't know the patient is pregnant and we get in there and the patient is pregnant, they're signing yes, we want the procedure to continue, or no, don't continue, stop the procedure, and we're done. So we have that. The next section we have is Capstar section, or flea medication section. The flea medication that we offer if a patient comes in with fleas is an oral Capstar. We don't want fleas in our clinic because they can spread to other patients that maybe they don't have fleas in their environment, or they're being treated for fleas, and we don't want to expose other patients to that. So if they have fleas, we go ahead and treat with Capstar, or they have the option of putting in another flea medication that they prefer. They went ahead and left that blank, so they went in with decided that yes, if my pet has fleas, we want Capstar. So next we have just talking about payment, all the different payments we accept, don't accept, our ID policy, and any information that yes, this also talks about I am giving consent to the clinic to perform the procedure, anesthetize my patient, and perform everything that needs to be done, and yes, you have my consent for that. So then we have the client's signature here, an emergency contact number, just in case anything happens. We want to make sure that we can contact them with a good phone number there. We also offer a text message service. We can text them, give them updates on their pet. Hey, your pet's in surgery, doing well, or your pet just got out of surgery, it's doing well. Some people opt for that because maybe they can't access a phone call right then. And that's our release and consent form. Okay, I'm going to be showing the proper form to identify the patient that you have in your clinic for a procedure. So this is all of Milo's information. So I have the sheet that we got from the receptionist about the procedure that we're going to be doing for Milo. I've made a cage card here. So the cage card has the owner's last name, the pet's name, today's date, whether or not the patient came in with a leash or a collar or a cat carrier. So he did come in with a cat carrier, and we went ahead and put the collar down there. The cat carrier is also labeled with a sticker that has the patient's name on it, so we don't lose that. We also have the procedure that we're going to be doing for him today. We're going to be doing his neuter, so that can also be correlated with his travel sheet and consent form. We also marked off whether or not we're going to be doing blood work for him, what his attitude is today. That can also help identify him, whether or not he bites or scratches. So we have that marked off. We also put name tags on all of our cats with the name, just in case cats get moved around to different kennels, somebody wasn't paying attention, they are labeled. We also put a picture in our medical record database, so if we get to a point where we really don't know who this is, we have a picture to look at that'll let us know who exactly our patient is. So that's all of the information that we do for marking and labeling our patients to make sure we have the correct patient. Alright, I'm going to be showing you guys our laboratory forms. So this is a printed off version of blood work that we did for a patient that we have today. So we have the patient's information at top. This was Jack's blood work. We have the owner's name up here, the breed of the dog and the age of the dog, so we know exactly who this blood work belongs to. So we have two different sheets here. The first one we have is our CBC readings, and this is all of the different reads from the blood. We can see that one of the values was high, and we would go ahead and let the doctor know that that value is high. But other than that, it looks really great. The next document that we have is our chemistry blood work, and we can see we tested just a pre-surgical one, so our BUN, our creatinine, our total protein, the glucose, and the ALT and the ALP, and all his blood work looks great, so we would give all this information to the doctor so they can make up the anesthetic monitoring form. Okay, I'm going to be discussing the anesthetic forms that we have for the patients. So if we come down, we have Miss Eve pulled up here. We have all of her medical records. So if we're going to scroll down to her medical record database, we have what's the anesthetic monitoring form. So I'm going to go ahead and open that up. And we can see this gives us all the information, her name, who her owners are, and she's a rescue dog. It tells us she's a canine, how old she is, how much she weighs in both pounds and kilograms, today's date. This also gives us all the information of, you know, who did her surgery, whether or not we placed a catheter. We have all of her pre-meds and induction drugs here. So she got a half tablet of carprofen before her surgery, and we can see that it's been checked off right there on the route that it was given. We can also see the pre-med drug that we use. We use a TT-Dex combination of Torb-Dex and Tilazol. The amount, we want to make sure we log that, so we have the bottle number there, the route that it was given, and that it's marked off. We also have our induction drugs. So we have Tilazol we use for induction, the amount that we're going to give, the bottle number again to log it, the route that we're going to be through, and that it's marked off with who gave it. We checked that the surgery pack was sterile. Her surgery was performed earlier today, so we have a full monitoring form here. We have the anesthesia start time, the anesthesia end time, the surgery start time, and the surgery end time. She was given ISO gas. Her ASA rating was a 1, and the size of her endotracheal tube. We have also all the numbers that we recorded for the length of her procedure. So we have the time that it was recorded, her heart rate, her SpO2. Initially, we didn't have her hooked up to a blood pressure machine. So once we were in surgery, we have blood pressure readings for her. Her systolic, her diastolic, and MAP. We have her temperature, her IV fluid rate. She was not hooked up to an IV fluid, so we have NA or none listed there. Her gas level, what her ventilation rate was. She was on 10 breaths per minute. And then her mucous membrane color. We have her hooked up to. These last ones, we didn't have her hooked up to that machine that tells us those numbers in surgery. So we have all those. We have before surgery, during surgery, and end surgery. If we were to go scroll down, if she were to have an emergency, we have emergency doses that's already pre-calculated for all the drugs that we use in our clinic. So we have all those there, and if they are given, we can initial them off that they are given, and that is our anesthetic monitoring form. Okay, I'm going to be discussing discharge instructions for a patient that was had a spay done today. So this is Bailey's, we call this our big day sheets. This is all the discharge instructions letting the owner know what happened with the surgery. So this is kind of a little, from the pet's perspective is what we call it. It tells them, you know, all the stuff that happened. You know, I was breastfeeding in my kennel, and then I got really sleepy, and my surgery was done. It's just kind of a cute little thing for the owners. But then down here we get a little bit more serious, talking about things to do for when they go home. So we have a little list here that says, you know, I may be really sleepy, a little sensitive to lights and noise, so go ahead and keep me in a nice, warm, quiet place away from a lot of commotion so I can relax. Also discusses, you know, I may be a little nauseous, so don't worry if I don't eat. Next we have the most important things to do, and this is talking about checking the patient's incision, making sure that, you know, I'm breathing, I'm not, I don't feel like, you know, the owner doesn't feel like having a bad reaction to any medications. It also talks about making sure that the patient doesn't lick the incision site, you know, swimming or getting wet until the sutures are removed, limiting activities, we don't want them running around and causing problems. Also, you know, it tells them to check the incision daily. And it tells them to go ahead and bring their patient back in 3 to 4 days for a recheck, and then 10 to 14 days for sutures out. So then we have the next day things to be looking at. You know, we want to make sure that eating and drinking has returned to normal, that they seem like they're themselves again. Again, another, check the incision site. We always want to make sure the owners are checking that site and nothing's happening to the incision site. Again, it reiterates, don't let your patient lick. Many of the patients will try to lick, and it's really important that that doesn't happen. Next we have what patient complications can happen. It discusses how it's a very common procedure, and minimal redness should resolve fairly fast, but we want to look for more serious things, and we go have a list that talks about pale gums, whether your pet's really depressed, vomiting and diarrhea are not but common and can be serious signs. We also want to look for discharge of the bleeding from the incision site. That reiterates with check your patient incision every day, and we really make that important that the owners know. Difficulty breathing, urinating, decreased appetite, and just an all-around lethargic looking. Those are things we want to have the owners keep an eye out for and make sure that they understand that those can be severe complications from a surgery. It also talks about the benefits from your surgery. So you get a little bit of the scary, gotta pay attention, but you also go, hey, you did a good thing for your pet. Talks about how it reduces population rates, it reduces cancer rates. It's just a really good thing. And that's what we have for that. That's our big day. We also discuss with them the interactions of the medications they're going to go home on. So we send patients home with medication for pain. So our dogs go home on carprofen, and we let them know most doctors choose a SID dose, and you want to give it once a day. There's complications that can happen with that. Reactions such as vomiting or diarrhea. We want you to, if that does happen, stop the medication and give us a call. It's usually pretty safe with other drugs. It could be mixed with, it's okay that it's taken with an antibiotic or another pain medication such as tramadol if it were extensive surgery. We want to make sure they stick to that regimen dosing that the doctor has prescribed. I'm going to be showing how to restrain for the different blood draws, the jugular, the cephalic, and the saphenous. So first for the saphenous, we want to have her aside, make sure I have her head, and we're going to go ahead and pull on her leg, and this will give the drawer access to the saphenous vein. Next, we're going to have Ellie sit down. Can you sit, Ellie? Good girl. I'm going to make sure I have her head in this arm, and then I would hold and roll this leg, and this gives the drawer access to the cephalic vein. Next, for the jugular, we want to go ahead and pull up her collar, have her in between my legs, making sure that she couldn't go anywhere if she tried to wiggle, and that gives the drawer access to the jugular vein. Alright, I'm going to be demonstrating how to appropriately and safely put a dog in a kennel. I'm going to open up the kennel door, dog in, and safely remove the slip lead. Close the kennel door, locking the kennel doors. Alright, I'm going to be demonstrating how to safely remove a dog from a kennel. Unlock the kennel door, move her a little bit, and there we are. I'm going to be demonstrating how to perform putting on a muzzle safely. So what you want to do is make sure you have the dog by your side. You want to stand behind the dog, slip the muzzle over her muzzle, and you want to fasten it behind her ears, back of her neck, making sure the muzzle is not rubbing on her eyes and is tight around her skull. I'm going to be demonstrating how to apply an Elizabethan collar to a patient. So I have Bailey here, and I have chosen a size 30E collar for her. So what I'm going to do is I've got it all put together, it's woven through, and it's not going to go anywhere. It's nice and secure. I'm going to go ahead and slide it over her face, making sure that the prongs don't touch her eyes. Pull your ears through. You can see that when her neck is stretched out, her nose does not come on the outside of the collar, and that's what we want. So now that I've got it around her head, I'm going to go ahead and use the gauze we have around the e-collar to tie it. Down, you want to make sure you can fit 2 fingers in between the patient's neck and the string, so you don't want to suffocate them. I'm going to go ahead and tie it in a bow, and that's how you apply an e-collar to a patient. Alright, this is Ruger, and we're going to be doing a comprehensive exam on him for if a patient were to come in to see the doctor. So the first thing we want to do is we're going to get a weight here. So I'm gonna have Lisa put him on the scale for weight. Sit. All right. So his weight today is 77 pounds and 3 ounces, so I'm gonna go ahead and put that into his SOAP exam. All right, then we're gonna come down here into a room, exam room. Come on, Ruger. Good boy. Okay. So now that we're in the exam room, I'm gonna get a temperature on him, and I'm gonna listen to his lungs, give him a look over him from tip of nose to tip of tail. So first thing I'm gonna do is get a temperature. Good boy, Ruger. Good boy. All right, so his temperature today is 102.1. Make sure I put that into my exam. All right. So next I'm just going to go ahead and listen to his heart and his lungs. All right, so his heart sounds good, nice and strong. I don't hear any murmurs. His lungs sounds clear, no crackling or wheezing. His heart rate was 90 beats per minute, and his respiratory rate was 45. All right. All right. So I'm gonna go ahead and start my physical examination on him. So I wanna start at the head. Good boy, Ruger. So we're looking up here, we wanna go ahead and we wanna look at his eyes. He has no discharge, doesn't seem to be red or irritated. I'm gonna go ahead and look at his gums, his teeth. He's drooling quite a bit, probably because he's nervous. All right, so his CRT is good, his mucous membranes are pink. He has some tartar on his teeth, mild dental disease, looks like, gingival. Okay, good boy. Nose is clear, not runny. I'm gonna go ahead and take a look at his ears. Ears look nice and clean. I'm just gonna go ahead and put them down. Run my hands all the way down his legs. I'm gonna make sure I check his pads. Good boy. Good boy. He's got a little mass on his chest. Make sure I note that in the record. Good boy. I'm just going to palpate his abdomen. He's not tense at all. I don't feel anything abnormal. Everything feels fairly normal in his abdomen. Good boy. I'm going to check his pulses. Good boy. All right, his pulses are strong. Check his back legs, his pads on his back feet. Good boy. All right, good boy. I'm going to take a look at his skin. Skin looks great, doesn't look flaky, looks nice and healthy. I'm going to check his lymph nodes. Good boy, Ruger. Good boy. Make sure along with the mass on his chest and his medical record. All right, good boy. All right. So you want to make sure that you put in a body condition score for pets when you're doing their examination. So as I'm feeling Ruger, I can feel his ribs, but he's not too skinny. He feels pretty good. He doesn't look overweight. Looking down on top of him, you can see a figure on him. So I give him a body condition score of about a 5. He's right in the middle. He looks really, really good. Good boy. All right, so no abnormalities were really found on Ruger besides the 2 masses. I'll make sure I note those in his record for the doctor to see. He was kind of a little bit drooly, which could be due to nervous. It's nerve-wracking to be here at the vet, so I'll make sure that the doctor knows about that. And that is a basic examination. All right, now we've done the physical examination on Ruger. We want to give him an ASA score. So since he has the dental disease and the tartar going on his mouth, if he were to come in for a dental, today I would give him an ASA score of 1. He's bright and alert, he's well hydrated, no concerns per owner, he doesn't seem to be in any physical pain, so he'd have an ASA score of 1. Okay, I'm going to be doing a exam on Pookie Bear here. So first off, we're going to get a weight on Pookie. Alright, 7.74, so I'm going to enter that into her soap exam. Next, we're going to get a temperature on her. All right, her temperature's 101.1, that's normal. That into the soap exam. So next I'm going to start my physical examination. So I'm going to start at the very tip of her nose and work my way down. So first I'm going to go ahead and take a look at her ears and her eyes. Her eyes look nice and clear, no discharge, no redness. Ears look pretty clear, not too much debris in there. Nose looks clear. Hi, sweetheart. It's okay. Mouth seems to be a little bit tender. Gums look a little bit inflamed or red, so she may have some mild dental disease going on. Next, I'm going to go ahead and feel her lymph nodes. Oh, look. Feeling down her spine. I'm going to go ahead and palpate her abdomen. Just be nice and gentle. Everything feels good there. I don't feel anything abnormal. Come back. Her lymph nodes back here. It's good. I'm going to check her pulses. She's got good, strong pulses. So I'm going to go ahead and just check the pads of her feet. Pookie, are you upset? Alright, take a look at her skin. Her skin looks nice and clear, doesn't look like she has any redness or flakiness, which all looks good there. Her feet look good. Everything looks pretty good on her. The only abnormality I've found is that her mouth seems kind of sensitive and her gums look red. She may have some periodontal disease starting. For body condition score, if you look down from the top of her, you can see the outline of her ribs. You can see a waist. She does seem kind of thin when you touch her rib cage and along her spine, so she'd probably get a body condition score of probably about a 4. She's not quite, she could probably stand to gain a little bit more weight, but other than that, she looks pretty good. She is an older lady. She is 12 years old, so for doing her ASA score, she needed to come in to say to have her teeth cleaned. She'd probably be a 2 because of her age. Other than that, she seems bright and responsive. She's a little bit sassy, so she's got some spunk in her. She's not feeling too bad. So just because of her geriatric age, she'd probably be a little bit more of a concern rather than if she was a 2 or 3-year-old cat. Other than that, she looks pretty good. I'm going to go ahead and take a listen to her heart and lungs. So we want to make sure you get a heart rate, a respiratory rate, and listen to her heart. Heart sounds good and strong, no murmurs, lungs sound nice and clear, no crackles or wheezing. So with that being said, I would still keep her ASA score of 2. Everything sounds good, but because of her age, we put her at a 2. I'm going to go ahead and enter her heart rate in here. Her heart rate was 130 beats per minute, and her respiratory rate was 50 breaths per minute. So, and her gums look nice and pink, so I'll put that in for her gums. She seemed well hydrated. Her gums didn't seem very tacky, and her skin tension is pretty good. So that is an examination of a cat. Alright, this is Ellie, and we're going to be drawing blood on her. We're going to be using the cephalic vein for this blood draw. My assistant is holding off the vein for me. So what we have are all the things I need. I have a 3cc syringe with a 22 gauge needle. I have my alcohol, and I'm wearing my exam gloves. So I'm going to go ahead and lift up her leg. Apply alcohol to the top of the leg. Palpate for the vein. Once I've palpated it, I'm going to remove the top off my syringe. Make sure my bevel is up and insert my needle. Once I've obtained the blood, my assistant's going to let go of the pressure, and we're going to put pressure on top of where the needle is. Hold it for a few seconds. And then we should be good. Alright, I'm going to be drawing blood from the cephalic vein of a cat. So I have my syringe and I have my alcohol. I'm going to go ahead and apply my isopropyl alcohol. I'm going to remove the cap from my syringe. Make sure the bevel side is up. And gently insert the needle, pulling back on the plunger. Once I've gotten my sample, my assistant's going to let go of the pressure. I'm going to hold off. And we're done. This is Ellie. We're going to be drawing blood on Ellie using her jugular vein. I have all the things that I need. I have my alcohol, my 3cc syringes with a 22 gauge needle, and I'm wearing my exam gloves. So what I'm going to go ahead and do is I'm going to place my finger at her thoracic inlet so pressure builds up in the vein. I'm going to palpate for her vein. I'm going to apply alcohol. Remove the cap on my syringe. Make sure my bevel is up, and then I'm going to go ahead and insert my needle. Once I've obtained the sample, I'm going to let go of her thoracic inlet, put my finger over where the needle was, and apply pressure for a few seconds. And we're all done. Alright, I'm going to be doing a jugular blood draw on a cat. So I have my syringes and needles, and I have some isopropyl alcohol. So I'm going to go ahead and hold off in his thoracic inlet to build pressure up in the vein. Put some alcohol in the area. Take the cap off my needle. Make sure bevel side is up. And I'm going to insert my needle. Alright, now that I've getting blood in my syringe, once I'm done, I'm going to release the pressure off the thoracic inlet, hold off, and remove my needle. And we're done. This is Ellie. We're going to be drawing blood from Ellie using her saphenous vein. I have everything that I need. I have my 3cc syringes with a 22 gauge needle, my alcohol, and I'm wearing my exam gloves. My assistant is holding out pressure on the vein. So I'm going to go ahead and apply alcohol to the area, grab my syringe, remove the cap, making sure that bevel is up. I'm going to go ahead and insert my needle. Once I've obtained the sample, I'm going to have my assistant release the pressure. I'm going to put my finger over top and hold off for a few seconds. And we're all done. Alright, I'm going to be demonstrating how to draw blood with the medial saphenous vein on a cat. Alright, so I'm going to go ahead and put some alcohol. So you can see the vein running right here, so I'm going to go ahead and take my syringe, my needle, cap off, make sure bevel side is up, and insert the needle, pulling back on the plunger. Alright, I'm going to slowly pull back. Once I have enough for the sample that we need, I'm going to go ahead and release pressure. My assistant is going to let go of the pressure on the leg, and I'm going to go ahead and pull out my syringe. And we have drawn blood. Alright, I'm going to be talking about what's called the minimum database. This is a procedure we want to go or protocol we want to go through with all young and healthy surgical candidates that come into the clinic. These are simple tests that can be easily done with minimal effort and minimal equipment. First, I'm going to talk about the packed cell volume, or PCV, which is also known as the hematocrit. This is the percentage of red blood cells that are in the blood. When you get a low PCV, it means low red blood cell production, and then the opposite. If you get a high PCV, you've got high red blood cell production. The reason this is a good idea to look for is these can point to signs of renal failure, parasite infections, autoimmune disorders, things like that. The next is total solids, or also known as total protein. These can indicate levels. These levels have a direct effect on the serum, on oncotic pressure, which deals with fluid shift. So if you were to have low total protein, you could be seeing edema in a patient, or on the opposite, if you have a high total protein, you could be seeing dehydration or malignancies. Next is blood glucose. But blood glucose, it measures the carbohydrate metabolism and endocrine functions of the pancreas. And these are really important things to monitor and really easy to check. Blood uronitrogen, or BUN, is tested to evaluate the kidney's ability to remove nitrogenous waste, which is called urea from the blood. And then next we have the alanine aminotransferase, also known as the ALT. This is an enzyme that's found in high concentrations in the liver, and it can give you a good idea of how your liver is functioning if you have, possible liver disease or anything like that. And again, these are just your basic, simple tests that you want to run on young and healthy surgical candidates. So with the minimum database requirements for patients coming in for surgical procedures, in my clinic we have requirements where if a patient is over the age of 7 for any procedure, they require what we call preoperative blood work, which includes a CBC and a pre-surgical chemistry, which includes the ALP, ALT, BUN, creatinine, glucose, and total protein. We also require this for any dental that comes in, no matter the age. Alright, so I'm going to be discussing additional databases that could be used if something was abnormal on a physical examination. First off, the doctor might start with basic lab work. That could be your basic pre-surgical blood work, or it could be something more in-depth, like a comp panel, which would include a wider range of diagnostic tests, and could be including the electrolytes. You may test for the electrolytes in the blood. If a patient is coming in with bouts of tachycardia, you may Your doctor may have you hook the patient up to an ECG and get an ECG on them, or possibly hooking them up for blood pressure, testing their blood pressure. Other types of additional tests could be radiographs. If a patient maybe has ingested something and is now vomiting, radiographs are a good way to help determine if the problem is there. Additional tests you could run are fecals, to test for parasites. More tests could be snap tests. So you could test for parvo, FVLV, FIV, and heartworm with those. So there's many different kinds of tests you can run if something were to come up abnormal on physical examination. Okay, I'm going to be discussing the effective anesthetic protocol to maximize pain management and provide adequate sedation for the patient. So once the doctor has done a physical exam and determined, the patient's health and the safety of anesthesia, they will have chosen pain meds. So the pain meds, this is Milo's anesthetic monitoring form. So we have the drugs that we're going to be using for Milo. Our pre-med pain management is we use injectable carprofen for our pre-anesthetic pain management. So like if we were going to give a dog an oral carprofen dose, we give cats injectable carprofen. So we can see here that our pre-med is in there for our injectable carprofen. The dose is there, the route that we're going to give it is sub-Q, and we initial that we've given it. We want to let that wait on the cats for about 40 to 45 minutes to reach maximum effective dose for them. If we do that too soon, if we give the injection and don't wait long enough, it can cause extra pain. The pain management won't be adequate and could cause complications with anesthesia and surgery and post-anesthesia pain management. So we want to wait an adequate amount of time for that. Next we have our pre-meds for the actual anesthesia. So we use a combination of butorphanol, dextromethorphan, and ketamine. We call it DTK. They all get mixed together. They're all safe to mix together in one injection. So we can see that they are split up here, and it lets us know. So we have dextromethorphan, which we use as a sedative. Also ketamine, which we use as a sedative, and then we also have butorphanol added in there, which is also a pain management. So they're getting, along with their carprofen injection, they're getting pain management through their pre-med induction medications as well. So they're all safe to mix together. They're all given IM, so they got 0.08 of each. They're all given IM, and initial off that they have been given. Once they are sedated, we bring them out and we lidocaine block them for intubation, and we use isoflurane to maintain anesthesia, to maintain a good anesthetic plane throughout the anesthetic procedure, so that they don't, they don't feel anything. They're safe, along with all the drugs that are already on board for their induction. The carprofen injection lasts for 2 days afterwards. So even though they got it today, they're going to be feeling the effects of that pain medication for the next couple days, so they won't feel post-anesthetic pain. I'm going to be entering a controlled substance drug log. So what I have here is a surgery chart for a patient that we did today. We have our controlled substance drug log all digitalized on our computer. Our morphine, hydromorphone, and phenobarbital are in a written log, but for our tilazol and our buprenorphine and ketamine, Valium, and midazolam, we keep that all digital. So what I'm going to do is I'm going to enter the date of today, right here. Then I'm going to enter the patient ID number, the owner's last name, and the patient's first name, what breed the patient was. He was a corgi. He was a male. His sex, we put his weight in. He was 20.5 pounds. Then we're going to put in the procedure he had. So he had a neuter done. Now we're going to go over to our computer and we're going to pull up his medical record. And this is our medical record database. We use EVET Practice Online. So then we're going to scroll down to his anesthetic monitoring form. Once that opens up, it'll show me all the drugs that we used. So we used surgery drug TT Dex for our induction. So I'm going to go ahead and find that on my log right here. We use 0.08 milliliters. Entering that, jumping over to our Tilazol section, we use 0.2 milliliters there. Then I'm going to go ahead and we used isoflurane gas. And we used no dextometer, then the doctor who did his procedure, and how long the doctor took. So the doctor took 24 minutes. And then we're going to hit save. And then we're all done. We've logged the controlled substances. Alright, I'm going to be talking about the non-rebreathing system. So this non-rebreathing system is hooked up to our oxygen supply. Our oxygen, first off, is an oxygen generator. So this oxygen generator is hooked up to our flow meter. This is going to, we can change this to the amount of oxygen we want to flow to the patient. So that comes up here to our vaporizer. This vaporizer uses liquid and gases for anesthesia and vaporizes them so they can be inhaled. So the mixture of oxygen and anesthetic gases then travels through our tubing all the way up to the patient. This is going to be delivered at a high flow rate, so it gets pushed directly to the patient. When the patient exhales, all the exhaled gases are then, because this is a high flow rate, are going to get pushed down this corrugated tubing instead of back through here. It's going to come down the corrugated tubing into our reservoir bag. So the reservoir bag can actually be turned shut off or open, depending on if we need to give the patient a breath or not. You always want to leave it open if you're not intending to do that, so the patient can exhale. So once it's open, then the waste anesthetic gases come directly out to our scavenging system, which is then directed outside. That is our non-rebreathing system. Alright, I'm going to be describing our rebreathing system. So first off, we have our oxygen line that's coming in here. This is delivering oxygen, which is then followed to our oxygen tanks, which live here in surgery. There's a line coming through the wall up down here. This is our scavenging system that's connected to tubing that directs it directly outside. So these two come down and connect. Your scavenging system connects over here. Oxygen comes down, a couple times loops, comes up to our flow meter. So first off, the flow meter, you can turn the knob and deliver an appropriate flow. You can choose which flow rate you want to deliver your oxygen at. Then we have an O2 flush, which we can use if we need to, if there's a ventilator attached, we could pulse it to fill up the ventilator. If not, you can use it to, if you have a patient that needs direct oxygen, you can flush your line of any anesthetic gases. So then the oxygen comes up to our vaporizer, which is filled with liquid anesthetic gases that are vaporized inside this machine, and we can turn on the flow rate or percentage that we want of that gas using this knob here. We want to make sure when we do turn it, we want to push down on the lock and twist the knob and let go, and that locks it in place. And then you can push it back and now it's locked. You can't turn it on by accident. So once you've got that, the mixture of anesthetic gases comes through the line through here to our inhalation. There are two flutter valves on top that alternate the pressure depending on whether the patient's inhaling or exhaling. So when the patient inhales, that mixture of gases comes up to the patient, into the patient here. Once the patient exhales, the exhaled gases come through here into our CO2 soda lime absorbent, and then out through our scavenging system. When we're using this system, we want to keep our pop-off valve open. If this is closed, a patient cannot exhale. There's also the reservoir bag, and this fills with the gases that come from the vaporizer, the oxygen, and the vaporized anesthetic agent. So when the vaporizer fills, you want to choose the appropriate bag for the appropriate size dog. If you need to give a breath to the patient, you can hold your pop-off valve closed, give a breath to the patient, and let it go. And that is our rebreathing system. Alright, I'm going to be talking about induction chambers. So I apologize, ours is old, we don't use it, but I'm going to demonstrate and explain how you do use it. So when you're using an induction chamber, you have two ports on the top. One is where your gas is going to enter to the chamber. So that's this is all your anesthetic gas and oxygen is entering through this, this port into the chamber. Your next is where you're going to hook your scavenging system up to. And ours is broken, it doesn't fit, but this is where it would go. So imagine that that is stuck there. So this is all the extra gases can exit out of this, so you're not just filling this box. The extra gas has somewhere to go. So you have oxygen and anesthetic agents coming in, extra gases leaving through the scavenging system, and that is a induction chamber. All right, I'm going to be talking about mask induction. So when you are doing a mask induction, you want to make sure that you have their masks securely tightened to your tubes that are hooked up to your anesthetic machine. This one is hooked up to a rebreathing machine, so the patient can inhale, exhale freely, pop-off valves open. So when you want to do this, you want to go ahead and hold your patient, and you want to cover the entire muzzle inside that cone, because you don't want any anesthetic gases to leak around the muzzle. So you can see this is a good fit. It is tight around the muzzle, and you're just going to want to hold that mask up against the patient. The patient will inhale and exhale however they want to. If they're they're a little bit nervous and they're inhaling and exhaling, breathing fast, that's perfectly fine. They can breathe however they want to, but this is a way to anesthetize patients through mask induction. Alright, so this is where our oxygen supply comes from. Our surgery suites have their own oxygen generators, but for our treatment area oxygen and emergency cart oxygen, they come from these lines. So we have tanks that are hooked to pressure meters, and then the lines run up and through to the different rooms. So we do have ones connected here just in case our oxygen generators fail. And then they come all the way up and through, and then follow the lines all the way to our treatment and down to our portable unit, down to our treatment unit, and that is where oxygen comes from. Alright, I'm going to be demonstrating how to do a leak test on an anesthetic machine. So I have our machine here. I've taken the scavenging tubing off, so I have a bag hooked up to where, a reservoir bag hooked up. Pop-off valve is closed. So what I'm going to do is I'm going to take my tube and I'm going to firmly press it in my palm, creating a really tight seal. And I'm going to press my O2 flush until our reading on our centimeters of water pressure is at about 20. And you can see that it is staying at 20. That means that we have no leaks in the system. It's keeping the pressure, and if it were leaking, you would easily see that pressure dropping back down, and you would be adding more oxygen, and it wouldn't be holding pressure. So we have no leaks in the system, and our pressure leak for the day is done. Alright, I'm going to be discussing and demonstrating the different types of anesthetic monitoring for anesthesia. So first I'm going to talk about our ECG leads. So we have the white lead, and there's these little clamps. So the white lead goes and clamps on to the skin underneath the right arm. Black lead goes on the left arm. Right lead goes on the groin area on the left side. And if we had a green lead, which we don't here, but if we did, it would go on the groin area of the right side. Next we have our blood pressure cuff. Back to ECG. Our heart rate is displayed on the monitor. These leads hook up to the monitor, and we'll display heart rate and also display a tracing of the heart rate, so you can see if there's if anything's happening with the tracing. Next we have blood pressure. When you're choosing your blood pressure cuff, you want to make sure that it covers, it wraps around and then covers greater than 40% and around, and that'll be a good way to choose your blood pressure cuff. Blood pressure is measured with systolic, diastolic, and MAP. Blood pressure can range during anesthesia, but you always want to make sure that your MAP is above 60. If it's above 60, it means you're getting good tissue perfusion, and that is important. Next, I'm going to talk about our SpO2. So our SpO2 monitor can be hooked up to several different places. It can be hooked to the tongue, the ear, the pad on the toe. If it's a male, it can be hooked to the prepuce. If it's a female, it can be hooked to the vulva. So the SpO2 is monitoring the amount of oxygen that is in the blood, and you always want it to measure between 90 and 100%. Next, we have our capnograph. So our capnograph is hooked to our tube from our anesthetic machine, which is hooked to our endotracheal tube. So it's measuring the CO2 output that's coming from the patient. When you measure this, you're going to see a waveform on your machine, and the top of the waveform is measuring the exhalation point of the CO2. So then we have our tube that's hooked to our respiratory monitor. So we have this guy hooked to our ventilator. So when we have our hooked to a ventilator for dogs, we like to have them at 10 breaths per minute. And for the pressure, we want to make sure the pressure is between 15 and 18 centimeters of water. Next, we have the esophageal temperature probe. So we can use an esophageal probe, or you can use a rectal probe for temperature. You may have trouble accessing the rectum during a surgery, so this is a good way to go. When you insert this, you want to insert it into the esophagus gently, about to mid-thorax, and that'll measure the internal temperature of the dog. Next, we have our esophageal stethoscope. So same idea for insertion. This goes inside the esophagus. When you are inserting this, you want to make sure you lubricate the end of this. You don't want to cause irritation. Insert this gently into the esophagus. You're going to be listening for the heart, so you want to go about mid-thorax. And once that is inserted, you can listen, and it's a good monitoring equipment for when you're having trouble listening with your regular stethoscope, or your ECG leads are just not working for you. Okay, so this is Lisa Carpenter. She's one of my preceptors. She's a CBT here, and she's the one that's behind all the signatures that you see. Hi. This is Dr. Judson. He is another one of my preceptors, and you're going to see him in a couple of videos as we do. Alright, this is Dr. Denise. She's one of my preceptors, and you're going to see her in some videos. Alright, I'm going to be setting a cephalic catheter on Ruger here. So the first thing I want to do is I want to go ahead and shave. I'm using a size 40 blade. I'm going to go ahead and shave a spot. Alright, once I have that shaved, I want to go ahead and scrub the area. So I have a betadine and alcohol scrub. So I'm going to take 3 betadines. And then rinse with alcohol. Alright, then I'll do one final alcohol. Alright, once I have that nice and scrubbed, I'm going to go ahead and uncap my catheter. Get that ready. So now that I have that nice and uncapped, I want to make sure that the bevel side is up, and I'm going to go ahead and insert the catheter. Once I have a flash in my stylet, I'm going to advance the catheter. I'm going to quickly transfer that, make sure my sharps are out of the field, and then I am going to secure my catheter with tape. Alright, once I have that nice and secure, I'm going to go ahead and put my injection port on the end of the catheter. Then secure the injection port. Alright, once that is done, I'm going to go ahead and give it a flush of saline to make sure the catheter is patent. I'm going to feel up here on. Alright, so the catheter is patent. The final step is I'm going to take some vet wrap and cover the entire catheter with only the injection port visible. so we can have easy access. It's okay. You're okay.
Good boy.
All right, and that is a cephalic catheter. All right, this is where we're going to be placing a lateral saphenous catheter on him, so I have everything I need. First, I'm going to go ahead and clip using a size 40 blade. All right, now that I have the site all clipped, I'm going to go ahead and scrub using my betadine and alcohol. I'm going to do 3 scrubs with betadine, 3 scrubs of alcohol, all alternating. All right, I'm going to do one last alcohol. All right, now that I have it nice and scrubbed, I'm going to go ahead and take my catheter. Okay, I want to make sure that the bevel side of the catheter stylet is up. I'm going to go ahead and advance my stylet, my catheter. So once I have a flash in the stylet, I'm going to go ahead and advance the catheter. Make sure that my sharps are out of the way. Take a little piece of gauze, just dab up the blood. We don't want that inside of our tape. Okay. Once that is done, I'm going to go ahead and secure the catheter. And when placing a lateral saphenous catheter, you want to make sure your catheter runs with the vein. So now that I have that secured, I'm going to go ahead and take my port, my injection cap. I'm going to replace the cap, put it on the catheter. All right, so now that's there. I'm going to go ahead and secure that. Now that I have that secured, I'm going to take my saline flush, and I am going to flush the catheter to make sure that it's patent. And it is. All right. Once that is done, I'm going to go ahead and take some vet wrap, and I'm going to cover the catheter to keep it secure and safe. I want to make sure I leave the injection port readily available. And that is how you place a lateral saphenous catheter. Alright, I'm going to be demonstrating how to give a sub-Q injection. We're going to be giving Zinnia a FVRCP vaccine. So I'm going to go ahead and put her sticker there. So when we give a sub-Q injection, we want to go ahead and tent the skin, remove the cap, make sure that bevel's up, insert the needle underneath the skin, pull back to make sure that we don't get lots of air. We didn't, so then I'm going to go ahead and inject. And we're done. Alright, so this is Zinnia. We're going to be doing an IM injection. This is a mixture of dextrometor, ketamine, and butorphanol. This is what we use to sedate our kitties. So I'm going to go ahead and give this IM. Dr. Chunson's going to hold Zinnia for me. What I'm going to do is I'm going to go ahead, back muscle, making sure to avoid the sciatic nerve that runs back there. Come on, Zinnia. What I'm going to do is I'm going to go ahead and inject. Pull back, make sure I'm not in a vessel, and give the injection. And that's our IM induction. Alright, this is Ruger, and I'm going to be demonstrating how to give an IV injection. So I have my assistant holding off his vein here. I'm going to have some isopropyl alcohol. So I'm going to go ahead and put that on there. So I have half a ml of saline that I'm going to give to him IV. Go ahead and take the cap off. Palpate for the vein. Make sure that bevel side is up.
Good boy. Good boy. Oh, settle. It's okay. Good boy. It's just a pick. Yes. Good boy. You're such a good boy.
Okay, so now that I have the blood, my assistant is going to let go, and I'm going to slowly inject. Then hold off. And there we go. Alright, so I'm going to be doing an IV induction for surgery. This is Tilazol for this patient. I have my preceptor, Dr. Neese, holding off the vein. I'm going to apply some alcohol over the skin. I'm going to go ahead and remove the cap off my needle. Make sure bevel side is up. Insert my needle. Once I get a flash, I'm going to have my assistant let go of the vein, and I'm going to give the drugs.
If nobody's busy, can I get some brown balls?
I'm going to go ahead and intubate. This tube's been chosen for the appropriate size. I'm going to go ahead and measure. So our, it's going to be tied off about right there. Head, push down, push the epiglottis down, and insert gently. About right there is where we're going to stop. I'm going to secure the tube to the patient. Once that's done, I'm going to take the cuff. I'm going to put the appropriate amount of pressure inside the cuff to inflate it. That's good. Okay. I'm going to be demonstrating how to put Optics Care eye loop into a patient's eyes that is going into surgery to keep her eyes lubricated. So I have my eye loop here. What I'm going to do is I'm just going to open up her eyelids, place a generous amount of lube inside the eye, making sure not to touch her her eye, and rub it around so it's across the entire eye. Alright, so when you are choosing an endotracheal tube to use, you want to go ahead, and the way you can measure it is you can look at the nose, so the tip of the tube here should fit nicely between the nares of the nose. Once you've chosen your tube, you want to make sure that your tube is not going to leak, so go ahead and take a cuff syringe and inflate your tube. You also want to make sure that you're inflating it to the appropriate amount. So when you have your endotracheal tube in a patient and you're getting ready to inflate it, you want to make sure that there's enough pressure that it bounces back, but it's not tight. If it's tight, you could be causing damage to the trachea, and if it's too loose, your gases can bypass the tube and fluid can get down into the lungs. So that is an important thing to do. You can see there's a little bit of bounce, but it's not bad. So this tube is holding and is inflated appropriately. So then when you are going to insert your endotracheal tube, you want to measure how long you're going to insert it in there. So what you want to do is you want to go ahead and take the tube and measure from the tip of the scapula to the edge of the nose. And that's how far you'll insert your tube, and that's where you're going to tie it and secure it to your patient. Alright, I'm going to be demonstrating how to palpate for a bladder and express if need be. So what you want to do is you want to feel in the abdomen, and you're going to go ahead and you're going to feel for a little tiny ball. It's going to be the bladder. And what you, if there is one, and she does have one, you can go ahead and squeeze it very, very gently. You don't want to squeeze very hard because you can risk rupturing the bladder. And you can see that she is urinating, so I'm just going to go ahead and gently squeeze. This helps the doctor visualize and have better access to the uterus for a space procedure. Okay, so now that her bladder is empty, I'm going to go ahead and clean off her vulva. All right, and the bladder is expressed. All right, I'm going to be demonstrating how to shave a cat for a space surgery. So when you're shaving, you want to shave from the xiphoid process all the way down to the pubic area. So what you want to do is you want to take your clippers with a size 40 blade, hold them at the appropriate angle, and gently shave away the hair. Alright, once I have my area shaved, I'm going to take a vacuum and vacuum up all the extra hair. Alright, now we're ready to scrub her. Alright, so now that we have her clipped and her bladder is expressed, I'm going to go ahead and scrub her. I am using a betadine and alcohol scrub. So what I want to do is I want to grab my betadine, and we're going to do 3 of each. So now that I have my betadine, you want to use a target style scrub. So you're always rotating your scrub so you're not as to contaminate the inside of the where the sterile procedure incision is going to happen. We are now ready to go into surgery. Alright, now that we have Zinnia prepped for surgery, we're going to move her into the surgical suite. So I'm going to go ahead and turn off her ISO, turn off her ventilator and oxygen, unhook her, and I'm going to move her into the surgical suite while keeping her sterile. time. She is all ready for the doctor for her spay. All right, this is Dory. I'm going to be demonstrating and showing you how to take vital readings for a patient that's in surgery. So she's all hooked up and she's having her spay right now. We have our Cardell monitor hooked to her. So what I'm going to do is I have her medical record open here with her anesthetic monitoring form. I'm going to go ahead and add a line number item for her during surgery time. I'm going to take her heart rate, her SpO2, her blood pressure, first the systolic, then the diastolic, and then the MAP. Then I'm going to go ahead and put down her temperature. She is not on any IV fluid, so I'm going to write NA. Her gas level is 1.5. I'm actually going to turn that down to 1 for her. Now she's on 1% ISO. Her vent rate for her ventilator is at 8 breaths per minute. And then her mucous membranes, we'll just go ahead and take a peek at her gums. They are pink. I'm going to go ahead and write down that they are pink. All right, I'm going to click save. And then I've just taken some vital readings for our little kitty in her spay. All right, if you have a patient that's going into cardiac arrest, you want to lay them with left side down, right side up, feet facing away from you, and you're going to want to use a two-handed technique for this breed of dog, which is a lab mix. So what you're going to want to do is you're going to want to apply chest compressions at about 100 to 120 beats per minute right over the heart. And then you're going to have an assistant who will be giving breaths with the ambi bag using, you want to make sure that your breaths, the oxygen that you're giving your patient is 100% oxygen, which is given with an ambi bag, and you're going to want to give breaths with the ambi bag at a rate of 10 breaths per minute. When you're giving breaths with the ambi bag, you want to apply enough pressure that the chest rises and looks and is full. And once you feel a little bit of pressure, you want to stop and release. You don't want to overinflate the lungs and cause more damage. All right, I'm going to demonstrate opening up a sterile surgical gown and gloves to prepare for scrubbing in for a surgery. So you can see that it is labeled gown. It's in the correct sterility date from the autoclave, and it is sterile according to the indicator strip tape. So we're going to go ahead and pull that off. To open this up. That one is open. I'm going to go ahead and open up the second one. Making sure I do not touch the inside. Okay, so now that that's open, I want to go ahead and open up my gloves. Making sure not to touch the case of the gloves inside there because that will be sterile, and we're going to dump that onto this. And once that's open, I'm going to go ahead gently drop that. So now those are all sterile and they're ready for me to scrub up, and then I will come back and grab everything that's sterile. All right, now I'm going to do my surgical scrub. I have both my cap and my mask on. I am not wearing any jewelry on my hands, and I have no nail polish on my nails. So I have all of my sterile iodine disposable scrubs that I'm going to use. I have 6 of them open because we're going to be doing 3 scrubs per manufacturer standard. So I'm going to go ahead and grab my first scrub brush. I'm going to put it in the sink, and I'm going to start with scrubbing my nails. You want to make sure that it's getting underneath your nails. We're going to do 10 scrubs. All right, so now that that's scrubbed underneath my nails, we're going to go down each side of my finger 10 times. And down to my thumb. All right, once that's done, I'm going to go ahead and scrub down the side of my thumb, that side of my hand, and the lateral side of my hand. After that's done, we're going to move to the palm. All right, once the palm is done, we're going to move to the back of the hand. All right, once the palm of the hand is done, we're going to move down about 2 inches away from the elbow. We're going to make sure we scrub all surfaces. grab my next scrub brush, making sure that my hand does not drop beneath my elbow. All right. Same procedure on the second hand. Underneath the fingernails 10 times. All right. Moving down the sides of the fingers. Each finger. And down the side of the hand. Moving to the other side of the hand. Then to the palm. And to the back of the hand. Once that's done, we're going to move down the arm 2 inches away from the elbow, making sure to scrub all surfaces. Okay, dropping that in the sink. I'm going to come over and I'm going to grab my next one. This is my second set. And we're going to repeat the process again. All the meanwhile, you want to make sure that you're taking in mind your sterile fields and you don't want to break sterility. Now going on to my last scrub. Alright, now that I have done all of my scrubs, I'm going to go ahead and rinse my hands off. So I want to make sure that my my hands never drop beneath my elbows. So I'm going to go ahead and squat. I just want to rinse from the tips of my fingers down, making sure that nothing touches the sink. My elbow does not touch. Making sure that I'm not breaking sterility all the way down. Once I am done rinsing, I'm going to go ahead and come over to my pack where I'll begin drying off my hands. Okay. For this, I want to make sure I grab the edge of the towel. And when you're drying your hands, you want to start at your fingertips with one end and work your way down. Making sure that the towel does not touch any part of you so it does not break sterility. Alright. Then I'm going to go ahead and grab the other end of the towel. Again, start at the fingertips. Working your way down. Alright. Then I'm just going to go ahead and drop the towel. Once I have that done, I'm going to go ahead and grab my gown. It's time to gown. So what I'm going to go ahead and do, making sure my hands do not drop beneath my elbows. I'm going to make sure that I grab my gown. I'm going to go ahead and pull it straight up. Straight up. Once that's done, I'm going to go ahead and open up my gown. Put my gown on. Alright, I don't want my hands to come out of the gloves, or the gown. So now my assistant is going to come tie me in. And my indicator strip was sterile, so this gown is sterile. Now that my assistant has tied me in, I'm good to go ahead and put on my gloves. Grab my gloves, open them up. So I'm going to be using the closed technique, putting on gloves. Now that I have my gloves open, I'm going to go ahead and grab with my left hand, grab the glove. I'm just going to pinch and flip the glove over. Once I have that, I'm going to go ahead and grab the edge of the glove. And I'm just going to roll it over the gown. Once that's on, I want to make sure that I have my entire the entire cuff of the gown covered with the glove. Once I've done that, I can grab the glove and the gown and advance my hand into it. I can adjust the glove, still making sure that my other hand is secured, mitted inside my gown. Once I've done that, I can go ahead and grab my next glove. Again, flipping it over. This time, everything is sterile in this hand, so I can go ahead and use my fingers. Grabbing the glove, pulling it over, covering the cuff of the gown, and then grabbing the glove and the gown and pulling my hand into the glove. Adjusting my glove so I'm completely covering that cuff. Alright. I am now scrubbed, sterile, and gowned and ready to assist the doctor with surgery. Alright, so I'm going to go ahead and demonstrate draping the cat. So our pack is sterile. Where the doctor is going to make this incision. I'm going to go ahead and clamp it in place. Alright. We now have the drape in place. Now I'm going to go ahead and attach my blade to the scalpel handle. So I have organized the instruments on the tray. I have all my instruments organized the way the doctor is going to ask for them. We're ready to start our study.
Stop, please.
on the instruments to make sure that nothing is left behind. Alright, so we have our 10 pieces of gauze. We have our 13 instruments. Everything that was used in the surgery has made it back onto the table. Okay, I'm going to be discussing the responsibilities of a sterile technician. First and foremost, you should maintain your sterility at all times. You should always be aware of where your sterile field is and make sure that you're not touching or near anything that could cause you to break sterility. If you do happen to break sterility, say you end up touching something with your gloves, the best way to regain sterility is have a non-sterile technician come in and open up some new gloves for you and to have them remove your old gloves and while maintaining sterility, so your hands will be inside the gown, and then applying new gloves and a sterile procedure. Another important duty for a sterile technician is to hand the instruments to the doctor. When you do this, this includes everything from your scalpel blade handle to your forceps. Anything they ask for, you need to be ready and available to hand those to them. You want to make sure that when you are handing your instruments over to the doctor, that they are handed over with handles down so that they can the doctor doesn't have to stray too far from looking away from the surgery site. Another important part of being a sterile technician is it's your responsibility to thread the needles. Make sure you put the scalpel blade on the scalpel holder, and so that's available for the doctors when they need it. You also want to keep your surgery site clean. This means removing any excess tissue that's removed in the surgery itself, or dabbing up extra blood with gauze. And this also includes moistening the tissue, so making sure you keep an eye on whether or not your tissue is getting too dry, keeping that nice and moist. If you do happen to drop an instrument, the best way to say you really need that instrument in your surgery, the best way to get that instrument back sterilely is to have it sterilized through what is called a flash sterilization, and this can sterilize an instrument in as little as 5 minutes, and then you can use it in your surgery again. Alright, so I have Jake here. He's a neuter for today. Dr. Stoner's performing his neuter. I'm just going to go ahead and take some vital signs and reading for Mr. Jake here. Okay, this is Kinley. She's here for a canine spay today. I'm just going to go ahead and take some vital readings on her. Alright, this is Loki. He is a feline neuter for today. I'm going to be taking some anesthetic monitoring readings. She's a feline spay for today. I'm going to go ahead and taking some monitoring numbers for her. So I'm going to go ahead and do that right now. to clean up a surgery suite after you're done with the day with all your surgeries, how to wipe everything down and put away your instruments, what you do with hazardous waste material, and sharps. So first of all, I'm going to go ahead and take all of our monitoring equipment and restraint equipment and put it away. So we just hang these on the wall so they're out of the way and easily accessible for the next day that we set up surgeries. So I'm going to go ahead and start hanging up our monitoring equipment. We always want to make sure that we put the monitoring equipment away really loose. If you put it away too tight, sometimes it can damage the equipment, and we don't want to do that. So we hang those out of the way. Those are all out the way. We want to go ahead and we want to unplug our surgery table. Our surgery table is heated, so I'm just unplugging it so the heat doesn't stay on. I'm going to wrap the cords up so they don't get tripped over or broken. We place those down beneath the table along with the pedal. Alright. So now that that's done, we want to go ahead and take apart our anesthetic machine. So we don't want the tubes hanging off the front because they can get damaged. So we're going to hang those up. Push this back so it's out of the way. Alright, and oxygen has been turned off. This is an oxygen generator, so we've turned that off for today, so there's no more oxygen going to this room. Okay, next. We want to use a broad spectrum disinfectant, so this is Cedar, and we're just going to spray down the table and lights. So we're going to start from the top and work our way down to the bottom. So you want to use paper towels. Spray down your paper towels. Wipe down everything, the handles, the top, the switch, all the way up the arm. Okay, then wipe down the underside. And we're going to put this one back up against the wall so it's out of the way. Some more spray. Surgery table. So we're going to put some more spray. You're just going to wipe down your surgery table. Alright, once that is done, we want to go ahead and take the tray that's in it and put it around. So you can see any debris and material that got inside the tray. You just want to wipe that up. This is where any extra fluid or blood from the surgeries would end up. So I'm going to make sure that all is out. Once that is done, you want to move down the pedestal. So wipe down each side of the pedestal of the machine, of the table, and then the base. Okay. Just make sure that there's no blood or extra fluid on any part of the surgery table where the surgeries are going to be performed. Then we want to take another paper towel, spray that down, and we're going to come over to our anesthetic machine, and we're just going to gently wipe down all the surfaces of this machine. So I'm just gently wiping down every little bit. Again, with our Cedar, top of the ventilator, each side of the ventilator. oxygen generator, up the lines, down the legs, each side. All right. All right. So that's all wiped down. At the end of the day, you always want to make sure that you refill your isoflurane. We use isoflurane here. Your liquid anesthetic inhalant. So you can see that our machine is full. It's all the way up to this top line here, so we don't need to fill it up today. But at the end of the day, you always want to check that and make sure that it needs to be filled. If it is empty, the reservoir is right here, and you just pour your inhalant inside that reservoir until the liquid reaches the top line of the gauge. So when that's done, we want to make sure that all the trash is off the floor. So you can see over here that the doctors have thrown some of their indicator strips and some gauze on the ground. So you just want to pick it up and make sure that everything that's on the ground gets into the trash. So then, once the floor's picked up, you can go ahead and take the trash out. So our trash here in the county that we live in, tissue is not considered a biohazard waste here, and we can throw them in the garbage. If we lived in a different county, we would have to take all of our tissue and put it in bags in our freezer, and a company would have to come and incinerate all of the tissues. But here, all of our testicles, uteruses, extra bits of tissue can go in the garbage. So this is, we have, our indicator strips, our tissue, so all of that is our waste. So that will get tied up and sent out to the garbage. And then we have more bags in the bottom of the treat bucket for the next day. We'll put a new bag in. So that will go out to the garbage. Right here. All right. As for our sharps, doctors leave the sharps. So the sharps, we want to make sure that we take off of the instruments and that the sharps are disposed of in appropriate sharps containers. This sharps container does not live inside our surgery suite. I'm just using it for demonstration purposes. We keep this in our treatment area. So all of our sharps are out there, but they do get disposed in the sharps containers. We want to make sure that all of our sutures are closed. Our packs will get taken out to be clean and rewrapped. Everything is pushed away and organized. Our computer for our medical record, the anesthetic monitoring, is closed. Everything looks to be in order. There's no blood or grime on any of the walls. If there was, we would spray it on the walls with the multi-purpose broad spectrum cleaner like you kind of saw. Once a week we do this. It's not today, so I'll just describe how it's done. But we just take a cloth and we wipe down from the very, very top of the window seals to the very, very bottom of the floors. At the very end of the day, we go ahead and we vacuum the floors and we mop with a broad spectrum floor cleaner. And that would be the very end of surgery cleanup. I'm going to be demonstrating how to properly clean surgical instruments after they've been used for a surgical procedure. So I have my instrument soaking in distilled water and detergent. So the detergent we have is Alkanox. I sprinkled some in there and put the distilled water in. I'm letting those sit. They've been sitting for about 5 to 10 minutes. So then I'm going to go ahead and open up my ultrasonic cleaner, which is also filled with detergent and distilled water. And I'm going to go ahead and take a scrub brush and some Chlorhex scrub, and I'm going to scrub each instrument. So what I'm going to do is I'm going to turn on some water, take the instruments, and I want to make sure that I scrub every side of the instrument, including underneath the identification bands. If the instruments have any kind of ravine or etching, you want to make sure that you scrub in both directions to make sure that you get all debris out of the instrument. If your instrument has hinges on it, you want to make sure that you scrub them with open and closed down all sides, including the handles. Rinse it off, put it in the ultrasonic. So I'm going to go ahead and finish scrubbing these. Alright. Once that is done, we're going to go ahead and put them in the ultrasonic cleaner, which will shake out any extra debris that I may have missed. So we're going to set that timer for 10 minutes, and when that's done, I'm going to dip the instruments in instrument lubricant. Alright, now that the instruments have gone through their 10-minute cycle in the ultrasonic cleaner, I'm going to go ahead and take them out, and I want to rinse them. I want to make sure I rinse all of the detergent off of the instruments. Once I have rinsed all of the detergent off the instruments, I'm going to take the instruments and I'm just going to dip them in the instrument lubricant. This is also mixed with distilled water, so we're going to use distilled water. The instrument lubricant helps the instruments move freely and keeps them nice and clean and usable. So once that's done, I'm going to let them dry, and once they dry, they'll be ready to wrap into surgical packs. Alright, I'm going to be demonstrating how to properly wrap a surgical instruments pack. So this is my wrap. It's a double wrap, so I'm going to go ahead and unfold it. I'm going to take this one out real quick, and I'm going to just lightly lint roll the inside of this. Make sure there's no hair on this one. Okay. I'm going to go ahead. This one. Do the same thing. Alright, now that that's done, I'm going to go ahead, flatten it, and start putting my instruments inside the pack. So I have my surgical drape. This is a feline drape, so I'm going to go ahead and set that inside the pack. I have my stack of gauze and my needles, and then I have my indicator strip, which will tell me and tell the doctor if the pack is sterile on the inside. So I'm going to place that in here, roughly towards the very center of the pack. We want to make sure that all the entirety of the pack got sterile in the autoclave. So once that's in there, I'm going to go ahead and take my instruments, making sure that none of the ringed instruments are locked. You don't want to lock any of them. You want the steam and sterility to make sure it gets to every single part of the instrument. So I'm going to set those there. Then I'm going to go ahead and start wrapping. You don't want to wrap too tight. If your pack is too tight, the steam sterility will not be able to penetrate the entire pack, and it will not be sterile. Do that. Fold it. Alright, making sure that there's a tab to easily open it. Once that's done, I'm going to wrap the outer portion of the pack. Right. You want to make sure that there are no gaps in your pack, no holes, that it's all sealed nice and tight, so you can see that this is wrapped snugly. It's not too tight, it's going to get sterile all the way through. So once that's done, you're good to go ahead and grab some tape, and you're going to want to label your pack. So make a little tab so it easily turn off. Alright. And you also want to put indicator tape on the outside of the pack to make sure. This will tell you if the pack was even sterilized. So this tape has these little lines on it, and when the pack has been autoclaved, these white lines will turn black. So that'll tell you that yes, it has gone through the autoclave, yes, it should be sterile. So now that that's on, I'm going to go ahead and label it. You want to label your packs with the date that they were wrapped, so today's date. And then you're want to go ahead and label what the pack is. So this is a feline spay pack, so I'm going to make sure I put that on this label. And then you want to put the initials. This will let people know if there's a problem with it, who wrapped the pack, so they can come to me with any concerns. And that is how you wrap. a surgical wrap. I'm going to be demonstrating how to properly wrap a surgical gown. So I have my gown laid out here. I'm going to start folding it. And I want to fold it so that when the doctor opens it, it'll be nice and ready for them to put directly on. Go ahead and use my outer wraps, and I'm going to open them up. Set that down there. And I want to go ahead and I want to lint roll these wraps. Go ahead and do that. Whoops. Roll them the other way. We want to make sure that there's no hair sticking on the inside of these wraps. Alright, now that that is done, I'm going to go ahead and take my gown, put it inside the wrap, and I'm going to go ahead and make sure the strings are right on top so the doctor can grab those and pull it directly up. I'm going to put my towel that they're going to use to dry their hands after they've scrubbed right on top. I want to make sure I put my indicator strip in the center of the pack. That's going to let the doctor know that yes, this pack has been completely sterilized to the very, very core, and I'm going to start wrapping. I want to make sure that I wrap it snug but not too tight so that enough pressure can get through the pack to completely sterilize it. Making sure I leave a tab so it can be easily opened. And then I'm going to go ahead and wrap the outer portion. Alright. Now that the pack has been wrapped, it's nice and snug. And you can see that there are no openings to the inside of the pack, so there's no chance that there'll be a break of sterility for that. Then I'm going to go ahead and secure my pack closed. Alright, and then I'm going to take my indicator tape. This is going to tell us for sure if the pack has been autoclaved or not. The little white lines on this tape will turn black when they have been properly sterilized. So make sure I put that on the pack. The next step is to label it. So I'm going to label it with today's date. And then I'm going to go ahead and put what kind of pack it is. So this is a surgical gown. And then I'm going to go ahead and put my initials. So if there's anything wrong with this pack, they can come to me with any concerns, questions, or tell me if I were to have not included the indicator strip, anything like that, so we know who wrapped the pack. And that is a properly wrapped surgical gown. Okay, now that I have my autoclave all packed, I'm going to demonstrate how to start it and describe the process. So the first thing I want to do is I want to make sure that I have enough water in my autoclave and that it's not going to harm the epoxy and the autoclave. So I have enough water. My coils inside are completely submerged, so that's good. So the next thing I want to do is I want to go ahead and turn the machine on. Make sure that I'm set to the right temperature for the packs. They are wrapped packs. We're going to go with the 273 degrees Fahrenheit. The next step is we're going to fill it with water. So I'm going to turn it to fill with water, and I'm going to wait till the water gets all the way to this edge in the front. That's going to make sure that we have the appropriate amount of water for the autoclaving process. So it can take a little bit of time. So I'll go ahead and describe what's happening inside the autoclave. So when we're autoclaving, this is a pressure autoclave. This is heat and pressure. So it heats up in there, and the pressure pushes all the heat into the packs, and it sterilizes them. from the outside in. So in theory, if it's autoclaved properly, you have that heat, that core temperature of 175 degrees is inside the middle of the packs and is sterilizing every single thing inside those packs. And the wraps keep the instruments inside completely sterile from the outside world for a certain amount of time. It's only good for a certain amount of time. So now that the water has reached the very edge, I'm going to go ahead and close the door before it runs out, and I'm going to tighten the door. We want to tighten this to hand tightness. Alright, now that that's nice and tight, we want to go ahead and turn it to sterilize, and we're going to set our timer for 50 minutes. Alright, so now that's all set. That's going to run on the sterilizing process. Once the 50 minutes has passed, we're going to turn it to dry and set it for on a separate timer for 10 minutes. So what that does there is that drops the pressure, because it's going to get up to 30 psi of pressure. It's going to drop the pressure down so it's safe to open. Once that 10 minutes is ended, we want to check this and make sure the pressure actually did drop, so not to harm ourselves in the autoclave. Once the pressure is back to zero, we'll go ahead and open the door and let it sit for another 20 minutes, and that'll make it completely dry. And that is how we start and run our autoclave. Okay, now I'm going to be demonstrating how to properly pack an autoclave. So I have two different levels in our autoclave, so I'm going to show you the proper way to do that. So I have my packs here. When you're packing your autoclave, you want to make sure that there's enough spacing in between each pack. If the spacing is too little, there could be a chance that there's not enough, there's too much contact and the pressure won't get to the inside of the pack. So I'm going to go ahead and pull the tray out. So when I put my packs in here, I want to make sure there's at least 3 centimeters in between the packs. So I'm going to go ahead and put those in there. Alright. Those are nice and spread apart. So you always want to put your smaller packs, if you have a two-tiered autoclave, you want to make sure that your smaller packs are on the top, and you want to put your larger packs on the bottom. Now I'm going to pull up my bottom tray, grab my larger packs, and put those in. You can see that the pack is not touching the top of the top tray. You don't want to do that because it can cause burning on your packs, which can lead to sterility problems. So now that all the packs are in there properly, you can see that it's properly packed and ready to start the autoclave process. Okay, so I'm going to talk about the proper time and temperatures for autoclaving. So if we're going to go ahead and autoclave wrapped packs, we want to make sure that our temperature is set at 273 degrees Fahrenheit. The pressure that it gets to is 30 psi. Anything above that becomes dangerous, so you should watch your autoclave and make sure that there's not a problem if the pressure gets too high. For packs, we set it at a 15-minute timer for the actual sterilizing pressure process, and then it goes on a 20-minute timer to dry, and then that's finished with that. If we're going to do a pouch load, if we're just running pouches, no packs, we drop the temperature to 250 degrees because it can cause damage to the pouches if the temperature is too high, and then you could have problems with sterility. The time is the same. We do, the PSI is the same. It does get to the same, about the same PSI. The time though is we set it for 60 minutes instead of 15 minutes along with the same 20-minute drying process. So that's the proper time and temperatures for autoclaving. Okay, I'm going to be describing how to maintain our autoclaves. This is our autoclave, a pretty big one. So when we go to clean it and maintain it, we want to drain out all of the water that's in it currently, and our reservoir's over here. So we drain all of that out, and we take out each individual tray and holding tray, and we wipe those down with a lint-free cloth. So all those get wiped down with a lint-free cloth, and we pull out and wait till we can put them back in after we're done cleaning. So when we have those removed, we want to clean the inside of the autoclave and the door. So we have cleaner that we use. So what we want to do is we want to open that cleaner and put the cleaner inside and we refill the distilled water. We put brand new, fresh distilled water in there, and we want to gently just kind of scrub over the inside of the autoclave with the cleaner in it, and that makes it clean. So then once we have that all done, we want to run a full cycle, and that'll flush the system and make it really clean. So once that's done, we drain all of the water again, and we wipe the entire inside down with another lip-free cloth, and we fill it up with brand new distilled water, and it is ready to go, and that's how we maintain our autoclave. Okay, so the ways you can tell whether the pack has been sterilized or not, you can see that this pack has not gone through the autoclave. It has not been sterilized. You can see the indicator tape on the outside has white lines on it. That's our first indicator that this has not been sterilized. If you were to open this pack, you would find an indicator strip with a yellow line through it, and that also indicates that this has not been autoclaved. If you move over to a pack that has been autoclaved, you can see that the tape does have black lines on it, and if you were to open this pack, the indicator strip would have a black line indicating that yes, this has been properly autoclaved and is sterile. Alright, so this is Daisy. She had a mass removal on May 10th, and today is the 22nd, so it's been 12 days. That's a appropriate amount of time to remove sutures. The mass removal is here, so I'm going to go ahead and remove the sutures. I have my suture scissors. Making sure the incision looks well, it's healed well. You can see that there's some crusties. Once you kind of pick, you can see the skin is healed. It's not red or irritated or swollen or looks like it's infected. I'm going to go ahead and pull out the suture. You just want to clip one side of the suture and then pull it out. There we go. If you end up clipping both sides, there's a chance that suture could be left inside the skin, and it could cause irritation or infection later. Alright, so now that all the sutures are removed, I will then take the chart and I'll make notes in the medical record that everything healed well and how many sutures I removed.